typical lab from our office. And I wanted to go through one example report, and this is how we do our lab reviews with patients in our office. This is what a pretty comprehensive lab report looks like for us. So this patient, we start with the NMR lipo profile and lipids. So I start and point out that right here is the standard lipid panel. So this is what most doctors check in their office. And then everything else on the page is part of our advanced lipid panel that we get for them. So total cholesterol is 213. That's generally regarded as high. I'm not alarmed by that. Triglycerides are 45. That's usually associated with insulin and glucose. So in this patient, that's exceptionally good. And the HDL is 82. So that's your good cholesterol. This is an excellent ratio for cardiac health right here. The LDL is, quote, the bad cholesterol. It is not bad. It is supposed to be there. This is marked as high on the lab report. In this individual, I told the patient I was not concerned about this at all, and I will explain why. So if we look at the LDLP, or the LDL particle number, it is under 1,000. So if we think about how this is done, if we take the test tube and we lay it on a scale to measure just the LDLs in the bloodstream, this tells us a concentration or a weight. If we then count the number of particles of LDL, that is the number here. So we know with the quality and type of LDL is really what modulates cardiac risk. We want big, fluffy, healthy LDLs as opposed to a lot of small, dysfunctional LDLs. So this tells you the count of them. Then when we go down to the small LDL count, you can see in this patient is exceptionally low, and we want it to be under 500. So this is a wonderful lipid profile. It would make me wonder if this patient was on any kind of medication, but I know for a fact that they are not. It tells you the LDL size as well. We want that to be over 20. In this case, it's 21.6. So again, an excellent lipid profile. As you look through here, it gives a little bit more detail on the number of the large LDLs. We want that to be high, and we want the small ones to be low. So perfect ratios here. We also get an LPIR score. So this is an insulin resistance score. We want that to be under 45. This is going to be based on the lipid profile and just kind of give us a risk score. But you can see in this patient, it is excellent. Moving on, we check an entire iron and B12 and folate, or B9. So the iron, the saturation and the iron look high, so we will keep that in mind. The ferritin is a little on the high side, but not elevated. Oftentimes when I recheck iron, unless they are an iron worker or have a specific exposure, it will be low or normal the next time. So I'm not overly worried about this one, slightly out of range, but we do want to keep in mind if someone's high and they're taking a lot of iron, we may want to make some adjustments. Or if they're very low, we may want to add certain forms of iron to augment them, especially if they're younger or have recent blood loss anemia. So we're pretty cautious with how we do iron replacement, and we base it on all of these parameters. B12, we like the B12 level to be around 1,000, so this one's good. And folic acid, or B9, we like that to be 15 or to 25-ish. You can see it's not deficiency unless it's under 3. I find patients to be symptomatic if they're under 15. So we'll probably recommend a B complex for this patient. And this is a spot check of the B vitamins. You can get more micronutrients or a deeper panel. It's just not on our screening panel unless it's requested specifically. Next are the thyroid labs. It kind of spills over to the other page. So we see the TSH, or thyroid stimulating hormone, the free T3, the reverse T3, the free T4, and then the antibodies. So I'll start with the antibodies. In this patient, thyroid peroxidase and thyroglobulin antibodies are both negative, so no sign of autoimmune or Hashimoto's thyroiditis. As we look at the rest, the TSH, I'm looking for that to be under 2.5. So if the TSH is over 2.5, that tells me the body may want a little bit more thyroid hormone. In this case, it's looking pretty good. The free T3, I like that generally over 4, unless a patient tells me they have a lot of energy. So sometimes this can be low if they didn't take their thyroid medication the day of, or if they got their labs drawn late in the day. So generally we do fasting labs early in the morning, and we try to get it about 5 hours after taking thyroid medication. Oftentimes our patients are given differing instructions, though, not to take their meds at all the day of the draw. So that's probably the case here. The T4, we don't really give a lot of credence to if we're giving medication, but remember TSH comes from the pituitary gland, tells the thyroid to make more hormone. And then the thyroid gland kicks out T4 if it's present. T4 is an inactive hormone, and then it gets activated to either T3, which is the gas pedal, or reverse T3, which is the brakes. And that either accelerates metabolism or slows it down. So you can see in this case, the reverse T3 is a little bit on the high side. So I'm pretty certain this patient is taking thyroid augmentation or thyroid supplementation to optimize the levels. This is what I would call kind of a subclinical hypothyroid picture, and looking pretty good. If they were tired, sluggish, cold, constipated, heavy periods, dry skin, losing their hair, I would definitely get aggressive and treat this to over 4 if they tolerated it and didn't have signs of excess thyroid with that. The other thing, the reverse T3 can sometimes go up if we are treating with thyroid medication and we're getting it a little too high. So if it wasn't elevated previously and it starts to go up, I look at the dose in my optimization a little bit more. Sometimes we see this high naturally without us intervening. That can be from inflammation, toxins, stress, things like that. So we want to look for the root cause of that. And oftentimes when we augment in those cases, we see the reverse T3 come down. The CBC with differential gives us a ton of information. So the white blood cell count is normal here. The hemoglobin is 14, so not anemic. And also in males, we want to look to see, especially if they're on testosterone therapy, if that's starting to get over 18, in which case we would have to treat that for erythrocytosis. Hematocrit is good. So these are the red cell indices, and you can see the volume and MCH are high. Usually I would think of those, remember the iron was a little bit high, so I would think of these being low if they were iron deficient, high if they're B12 or folate deficient. In this case, I'm not going to make too much of it. Might give us a little bit of information regarding that iron. The platelet count is over 200. So if we're thinking about doing PRP therapy, we want that to be over 200. In this case, it's good. Next, we're going to look at the neutrophil to lymphocyte ratio. So your neutrophils are the guards on the castle wall. So they're the ones that defend from attack from anything the same way. Then we have the lymphocytes, which are that targeted attack if there's a breach of the castle. So if you think of your body as a castle, neutrophils are the guards, lymphocytes are your attack dogs. So we want that ratio to be 1:1 or 2:1. You can see in this instance, we actually order it so it's calculated, it's 5.8. So during COVID, we looked at this. Normally, we would call this a left shift, right? You're going to shift guards to the castle wall if there's a threat or attack. We want to see that balanced out in a healthy individual. So sometimes this is just because they were sick. I never take any one of these as to be too concerning. It's a snapshot in time, and I want to look at trends over time before we put too much meaning to that. But overall, that would be the only thing really concerning on this CBC. Next is a comprehensive metabolic panel. So this is looking at kidney and liver function. The fasting glucose here is 100. We like it between 70 and 85. It's not uncommon that sometimes patients who run normal are even up in the 90s. So we're going to look at this. Again, the blood sugar fluctuates all the time. So one value isn't going to make or break us, but we're going to look at trends. We might do a continuous glucose monitor. In this patient, remember the triglycerides so far are looking pretty good. The lipids were looking pretty good. So we will look at the fasting insulin and the A1C and see if this is a trend that's causing problems in other places, or maybe it's an isolated issue. So in this patient, the BUN and creatinine are both in the normal range. Creatinine might be low in this individual, either very good hydration or low muscle mass. So we would look at those two things. The sodium, potassium, chloride, CO2, the electrolytes all look good here. You can see the EGFR is excellent. Calcium is good. The synthetic functions of the liver are good. So the liver's job is to make a lot of proteins. That's a key function. Everything looks good there. And then the last three are filtering functions of the liver. You can see that the AST and ALT are 38 and 45. I generally like those less than 20. So in this individual, we're going to be looking at a fibroscan. We're maybe going to be starting some supplementation like TUDCA or milk thistle to try to support the liver a little bit. We'll ask in the history and see if there's any exposure. Alcohol, we're not getting a lot of metabolic syndrome that we're looking at here, maybe recent infections, medications that might cause some stress on the liver. So again, just being very nitpicky with this, I like those under 20. The LDH, lactate dehydrogenase, is kind of a marker of tissue damage or stress on the tissues. You can see this one's just a skosh on the high side, so we will recheck that and follow up. The breakdown of the LD fractions, sometimes in cancer patients, this can give us an idea, be that early warning sign if anything's showing up in tissues. So each one of these is assigned to specific organs and, again, tells us where to look if there might be looming problems. G6PD is glucose 6-phosphate dehydrogenase. This is an enzyme that we're looking for in patients who might want to do high-dose IV vitamin C or ozone. This is the enzyme that the cells need to process those treatments and can be a reflection of inflammation if they're high, or G6PD deficiency if they're low. That can be a reflection of mitochondrial problems or genetic variations. So this patient is right in the middle range. I would go ahead and proceed with that. PSA, this is for men. Prostate-specific antigen is a very rough screening test for prostate cancer. You can see in this patient it's less than 0.1. We're going to, again, trend this over time. In men, if we get over 4 or we see a sharp increase, we want to get on top of that sooner. Hemoglobin A1C, most people are familiar with this. It's tied to the average blood sugar over 3 months. So really what it is looking at is how many of those hemoglobins have a glucose attached to them. We want to see this around 5.0. This one is 5.6. Anything above 5.7 suggests that we're in pre-diabetic mode. So this is a little bit disproportionately high compared to the triglycerides. So there may be something going on here that we're going to look at. So a continuous glucose monitor and maybe some diet counseling to see, are they eating high carbohydrate meals or maybe not ordering their meals in the right order where they're spiking their glucose and insulin to drive this up. So that may be what's going on here. Testosterone and estradiol, again, this is a male that we're looking at, hopefully. So the testosterone level is good. The estradiol is about 10% or less of that. This may be a little bit on the high side because the liver metabolizes testosterone to estrogen. So we may be seeing a little bit of imbalance here, just a little stress on the liver. Next, we're going to look at the iodine level. In this patient, it is in the normal range. The vitamin D, the 25-hydroxy, we want this to be 60 to 90. So in this patient, I would increase this to at least 5,000, if not 10,000 IU a day of D3. And we generally prescribe that with K2 also. As you remember, K2, as D3 pulls calcium into the bloodstream, K2 is going to make sure it gets to the bones instead of settling into the blood vessels. C-reactive protein is one of the most important labs on a test. My phone always wakes up when I say that, thinking I'm talking to Siri. So the C-reactive protein less than 1 is very low risk. You can see this one's excellent. Anything under 3 is pretty reassuring. Anything starting to get higher than that, and we want to investigate. It's very non-specific, so as that number goes up, it can go up with almost anything. It doesn't tell us where it's going. We do need to dig if that number is elevated. Myeloperoxidase, the next two are advanced cardiac markers. So myeloperoxidase looks at vascular inflammation. In this case, the patient is in the high normal range. We do start to see that come down when we address vascular inflammation. OX-LDL. LDL is part of our immune system and absorbs free radicals and becomes oxidized or rusty. So in this patient, again, high normal range. A lot of time I'm doing something like Lipitrol or increasing pomegranate juice in their diet to bring this number down. It has a really specific antioxidant that works like a sponge to help absorb some of the free radical damage and will take the stress off of this. You can imagine you don't want rusty cholesterol balls circulating in your bloodstream. So that's kind of a rough visualization of what this measures. As we wrap up, turn the final corner here, homocysteine is an amino acid that gets recycled by B vitamins. The optimal on this is around 7 to 8. His is a little bit high. I think that's probably because the folate level was on the low end of the spectrum. So we will go ahead and replete with methylated B vitamins. If we don't see this come down, then I'm starting to think it might be an MTHFR variant issue or another problem with downstream methylation. So 10.5 isn't super alarming. If it gets over 12, I'm starting to think of things like vascular health and blood pressure. Uric acid is a marker of protein metabolism and it's tied to gout. This patient is in the normal range. Sedimentation rate, this is another inflammatory marker. This one is well in the normal range here, so looking good. The insulin level. Fasting insulin is probably one of the other very important variables here. We would like the fasting insulin for most patients to be between 5 and 10. This one's riding a little bit high. So again, using a continuous glucose monitor, looking at the diet, looking at how the patient eats may need a little bit of work. Lastly, magnesium. RBC. So we check the intracellular magnesium. A lot of times most doctors and hospitals check a serum magnesium, which checks a 2 to 3 day supply of magnesium in the water part of the blood. This actually checks the intracellular part of magnesium, or the 2 to 3 month stores. We like this number around 6. The patient's at 5.9, so they're in good shape. LabCorp is very nice. They provide a visual graphic, and you can see in this instance, all of those labs fall to the good and in the green zone. So we're happy with this, and just another visual representation. So all in all, this report is very good. We do have a couple of issues to work on with the iron, maybe the metabolic syndrome. And so you can apply that to your lab as you see fit. Drop your questions below.